Welcome and good afternoon. Thank you for everyone for joining us for our third session of Antibiotic Stewardship, Practical Implementation for Kansas Facilities. This is a this is the third session of a four-part series predominantly in support of Kansas hospitals, yet all are invited and welcome to attend. We welcome everyone who has taken the time out of your busy schedules to be here with us today. My name is Heidi Corson. I'm a Quality Improvement Advisor with Kansas Healthcare Collaborative, and I'm pleased to serve as your facilitator today. This session is being recorded and will soon be available for viewing online. Today's session is approved for one continuing nurse credit hour as well as one pharmacy hour. For nurses who would like to earn credit, you will need to respond to each of the 5 polling questions throughout today's event, as well as return the C&E form, which was sent to your email yesterday. Please make sure that everybody is muted. Today we are using Zoom meeting instead of Zoom webinar so that we can have our breakout sessions. So just make sure that as you log in and switch from breakout sessions into the main room that you are muted. As I was saying, today's session is approved for one continuing nurse credit hour as well as one pharmacy hour. For nurses who would like to earn credit, you will need to respond to each of the 5 polling questions throughout today's event, as well as return the C&E form, which was sent to your email inbox yesterday afternoon. Pharmacists who would like to earn credit for today's session do not need to return the C&E form. However, we do hope that you participate in our polling questions. Next slide. So this is a lineup of our series. Like I said earlier, today's event is session 3 of 4. And if you missed the first 2 events, a recording can be found in the KHC Education Archives using the links on the slides. Today, our speakers will go into more detail on how and what metrics to report. And a little later on in our program, as I mentioned earlier, we will have 2 breakout sessions, one for basic reporting and another for more advanced reporting. And we hope that you have come prepared to engage and ask questions of our speakers. Our final session will be on July 7th, and our speakers will tie all of the information that they've provided together and provide interventions tailored to your facility. Next slide. Today, we have the pleasure of hearing Dr. Wark and Nikki Wilson both speak. Dr. Wark is an assistant professor of infectious disease at the University of Kansas Medical Center, as well as a subject matter expert of antibiotic stewardship, healthcare-associated infections, and antimicrobial resistance in the Kansas Department of Health and Environment, HAI-AR program. She is trained in internal medicine and infectious diseases, working across the academic, clinical, and public health spectrum. At KU, she serves on the Antibiotic Stewardship and COVID-19 Therapeutics and Vaccine Task Force committees. She also serves as the state HAI-AR Advisory Subcommittee on Stewardship co-lead. Next slide. Our second presenter is Nikki Wilson. Nikki is the Antimicrobial Stewardship Program Coordinator for the University of Kansas Health System, where she serves as the Residency Program Director for the Postgraduate Year 2 Infectious Diseases Pharmacy Residency Program. She is a board-certified infectious disease pharmacist and a co-lead for the antimicrobial stewardship efforts under the Department of Health and Environment's HAI-AR program. And at this time, I will turn the presentation over to Nikki. Nikki, I'm not able to hear you.
Sorry about that. Had my phone on mute. Good afternoon, everybody. Thank you for joining us, and we're really excited to have you for session number 3. Bill, if you could go to the next slide, please. So as mentioned before, we are really going to talk about what metrics to report and how to communicate that information to various other clinical or administrative staff in this session. And we'll have 2 separate breakout sessions available that we'll talk about a little bit more in detail as we get closer to that. However, to start our session off, I did want to do a refresher of some of the information that we talked about during our last session. Next slide. And I apologize, my voice is a little weird today, so please let me know if that is a problem. But essentially wanted to just reinforce some of the discussion that we had around numerators and denominators, and really focusing in kind of on our days of therapy numerator in addition to our defined daily doses. So we did talk a lot about that at our last session. The denominators I wanted to go into a little bit more because we did get some questions about that. So specifically wanting to focus on the difference between days present and patient days in relation to patient admissions. Next slide. Okay, so again, denominators, whatever you choose, make it what is easy for you to access at your facility and what you can use on a consistent basis. So some people actually utilize number of admissions, and this is probably going to be your smallest denominator, because if you think about it, a single patient being admitted to the hospital will ultimately contribute potentially multiple patient days. So a single admission may actually relate to 10 patient days, for example, if they're receiving antibiotics for that long. So that's going to be your smaller denominator. And then patient days and days present, we'll talk about kind of the difference in comparison in just a second here, but I do think it's important to note that typically your number of patient days that you're able to access is going to be slightly smaller than the number of days present. And that is because in the days present denominator, one patient on one patient day actually can contribute multiple days present, depending on their movement throughout the hospital and the antibiotics that they receive. Next slide. Okay, so this may look a little familiar to those of you who were able to join us for the second session, but I wanted to bring this back just to try and take a little bit more time to explain it. So I'm a visual person. I'm hoping this visual is helpful. But again, just a reminder, number of patient days is essentially butts in beds at a designated time. Most places use midnight of that same day. Some other hospitals use different times. It's okay. It's just a patient in a bed is one patient day. And so you can see with our single little blue patient here, they're contributing a single patient day. However, if we're calculating days present as the denominator, this patient actually contributes a total of 2 days present, 1 day to the medical surgical unit and 1 day to the operating room where they were transferred and received, hopefully, perioperative prophylactic antibiotics. So this is kind of a little bit of an illustration for a single patient, how they can contribute multiple days present, even though they're only technically one person. Next slide. Okay, so then it starts to get more complicated as we add in more patients, right? So in this example, we now have 2 patient days that would be attributed to our denominator, our blue patient and our orange patient. Ultimately, though, each of these patients is going to contribute 2 days present to various locations for a total of overall 4 days present. So again, focusing on the movement of the patient, right? We have our blue patient who's contributing 1 day to medical surgical and 1 day to the operating room. Whereas with the ICU patient, or with the orange patient, they're contributing 1 day present to the ICU and 1 to the medical surgical unit because they were ultimately transferred and received an antimicrobial on that unit during that calendar day. So you can see if you have a hospital of if you have, probably more than 5 or 10 patients present in a day, it can be difficult to track down the actual number of antibiotic administrations and when those occurred and at what unit. There are a variety of different ways you could potentially do this, either from EMR administration data, from patient ADT transfer status, but typically in order to really truly determine the number of days present, it's going to require some data manipulation and compiling information from multiple sources. So if any of you out there are actually doing this and not utilizing a software company for this, please let me know, because I would be extremely interested in your methods and hopefully would be able to share some of that information with our colleagues if needed. But ultimately, overall, days present typically larger than patient days, but much more challenging to calculate and accurately attribute antibiotic administrations to those patients. Next slide, please. Okay, so bottom line is that you really need to understand the methodology that other health systems are using if you're going to try to do a direct comparison. So like, I know I have, stewardship friends across the country that I'm like, hey, how many DOTs do you have for this? Kind of just trying to figure out where we're sitting without using any formal comparison. But if one facility is using a DDD with admissions as the denominator, and the other is using DDDs with patient days as a denominator, even within what someone is calling a DDD or a DOT may not be the same if you're not using the same numerator and method to calculate your denominator. So hopefully you're excited and go away and want to compare some, AU with your friends, but just be mindful of the fact that each individual facility, whether they call it a DOT or a DDD, may have different methodology. And so direct comparison, proceed with caution if you can. Next slide, please. Okay, so this is leading us into our polling question, number one. So please make sure that you are answering our polling question, especially for CE credit. But so this denominator for antimicrobial utilization metrics does not account for patient movement throughout the facility and corresponding antimicrobial administrations in each location. So is that admissions, patient days, days present, or days of therapy?
We still have quite a few responses coming in.
Okay.
Okay, let's close the poll.
Okay, great. Yes. So we're seeing kind of a good split, but essentially, yes, your patient days and technically even patient admissions do not account for any movement in the facility. It's really that days present denominator, sorry. The days present denominator is the one that accounts for the movement throughout the facility. And then days of therapy is typically our commonly utilized numerator, whereas days present is commonly used denominator when you're looking at the NHSN format for days of therapy or DOTs. So thank you for your responses. Next slide. Okay, so we are going to get ready to transition into our breakout rooms. And so Heidi is gonna get those sorts of things set up, I think, now. And essentially, I think you can choose either breakout room depending on what your level of comfort or experience is with your antimicrobial stewardship metrics. So breakout room number one is going to be really our essentials of antimicrobial stewardship metrics and kind of reviewing and discussing commonly utilized metrics like DDD calculations, taking into account cost, C difficile, and then focusing on some interpretation and information sharing as well. And then breakout two is going to be our more advanced metrics. So if you have access to DOTs, we're going to talk a little bit about interpretation and trending of DOTs, along with some other parallel initiatives. And then we're also going to start talking a little bit more about the NHSN reporting and the standardized antimicrobial administration ratio, how to use that and kind of interpret that information. So take a second and figure out which breakout room you are interested in. When you're ready, there should be a small little square at the bottom of your menu, and you can click on that and choose which room you'd like. Again, if you go into one and you're finding it's not the right fit for you, please feel free to move over into a different breakout room throughout the session.
And it will take us a few minutes just to get everybody situated in a room. So just make sure that when you get to your breakout room that your video is off and your line is muted, please.
we are waiting for people to hop over and get everything set up, if you guys have a second and want to put in the chat kind of what your role is in handling antimicrobial use reporting, that would be great. I'm kind of interested to see, I know I'm seeing a couple pharmacist names on here that I know, but curious to see if we have some infection preventionists or anybody else that is contributing to AU reporting on a routine basis. So if you have a sec, go ahead and pop that in the chat. And then that's how we'll also do all of our polling questions. So if we do have RNs that need CNE credit, that'll be how we're tracking your responses for CE credit as well. Heidi, do you need to start the recording before I can screen share?
I believe we are already recording. Are you able to share your screen?
Oh, well then, yes, I am. Let's
Okay.
go ahead and get started. Sorry. All right, yay, technology. So thank you for joining this breakout session. This is breakout session number 2, some of our advanced antimicrobial stewardship metrics. I do have some slides here that are prepared that I have some topics I'd like to cover. However, I do want this to be interactive if possible. So throughout the session, if you have questions or have input, maybe have some thoughts outside of what I've displayed here, please feel free to either unmute and chime in or use the chat to participate. But I want to make sure that you're getting some useful information you can take away and have in your day-to-day practice. So we do have a polling question to start out, of course. So I think a lot of the responses that we got for people interested in this session indicated that they were utilizing DOTs as their metrics. So my question for you to start out is, which denominator is your facility utilizing for DOT calculations? Is it patient admission, patient days, or days present? So, and then Heidi, I unfortunately cannot see chat responses while I'm sharing my screen.
I will make sure that I let you know what people respond. So like Nikki said earlier, we're not able to use the polling feature in breakout sessions. So please put your response in the chat and we will discuss as those come in. We've got a couple folks saying patient days. Days present.
I figured it out. Yeah. All right, patient days, days present, perfect. Patient days, love it. Okay, great. This is extremely helpful. Thanks, guys. So yeah, seeing majority of patient days, I do see days present. So might have some more follow-up questions for you in just a second on that. But all right. So again, just a quick reminder, patient day is not the same as days present, and patient days might actually result in a higher DOT estimation. Honestly, again, nothing wrong with that. Keep consistent your methodology and what you're doing, and I think that is the most important thing. So for those of you that are still kind of doing this data manually, use what you have access to, and that's really what's most meaningful for internal trending. Okay. So representation and trending of DOTs. I'm bringing this up because we did get a couple questions about this after the last session. So one of the questions was regarding aggregate DOTs versus DOT on an individual medication level. So I honestly utilize both in my institution, and I have a feeling other institutions do as well. Really, there's nothing wrong with using an aggregate DOT estimation instead of, going down to the individual medication level. It's just a difference in the granularity of the data that you're able to access and really kind of utilize to drive your action. So seeing an overall decrease or increase in your aggregate DOTs can still provide some information for action. It's just different than when you're looking at an individual antimicrobial. I have some examples in the next couple of slides that'll show this, but let's say, for example, you're trying to decrease Zosyn use and you're successful in doing that, but you shift use to a different antibiotic, your overall utilization trend may not change, even though you've accomplished your objective. So I think that, if you're able to get the individual antimicrobial data when it's meaningful for you for targeted initiatives, I think it's really helpful. But again, aggregate DOTs, I think, are very reasonable to trend and can still tell the story of antimicrobial stewardship. So that's the example of the graph that I have here. Is just, honestly, it's an example of our aggregate AU trending. And this is when we were actually using DOTs per 1,000 patient days before we were able to do the days present calculation. And so you can see, some very different swings in antimicrobial use. Ignore this huge drop here towards the edge of the graph. I think you all probably have seen this with COVID, where antibiotic use and patient admissions were way, 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 way down. So this is kind of a weird blip here. But anyways, this is just an example of kind of what you're looking at with overall AU. But again, it doesn't necessarily give you the level of detail sometimes that you'd want. One of the other ways that we actually trend our DOT data is to look at different routes of administration for the same medication. And Levaquin's a real easy target for stewardship programs just in general, but again, it's one of those IV to oral switches that our pharmacists typically are involved in. And so what you're looking at is a stacked bar graph of, with the orange is our IV use and the gray is our PO use. And so if you are to compare, say, the fifth bar, I'm not sure if you can see my mouse or not, but this fifth bar over from the left, if you compare that to, the bar, I think over here, 3 or 4 bars to the right, they're the same amount of utilization, but a higher use of PO instead of IV. So again, this can help tell a success story to administration because you're looking at fewer needs for IV and you're looking at the cost savings with oral drugs. And so sometimes even, digging down into route of administration and presenting it in this sort of fashion can help show where your efforts have been targeted. Okay. I mentioned this earlier, and most of you are probably familiar with the whole squeezing the balloon phenomenon, where we're reducing the use of one antibiotic, but potentially compensatorily increasing the use of another one. When we're doing these evaluations, what you're looking for is antimicrobials that have a specific either spectrum of activity that are similar to each other or similar indication or niche use. So for example, one of the things that we co-trend routinely are our anti-pseudomonal beta-lactams. So we look at meropenem, cefepime, and piptazo all together to really see if we're seeing a reduction in piptazo, which we have. Did we see an increase in cefepime or meropenem? I can tell you, at least with what we've seen, yes, we're shifting use from, piptazo over to cefepime, and that might not necessarily be in alignment with our goals. And so it helps identify what are our next steps that we really need to take within the stewardship program. One of my other favorite examples of this, of course, I'm going back and picking on my quinolones because they're just so easy, is really looking at the type of this following kind of example in this observation. So you have levofloxacin DOTs, and this is IV and PO. Oops, sorry about that. IV and PO together, and you can see a downward trend. But with ceftriaxone, we're seeing the upward trend in use as well. So this kind of created an alarm in our physicians' brains of, wait, why are we seeing so much ceftriaxone use? And so what we did is we co-trended both ceftriaxone and levofloxacin together to really get an idea of, is this a true just shifting use from one to the other, or are we still seeing some overall reduction? And what are our opportunities for improvement? And being able to display it visually like this, I think, again, even just looking at the lines here, you're looking at a total overall decrease in utilization, even though we are seeing a little bit of shifting of use. And so I think strategies like this can be helpful if you're seeing an increase in, even in cost, if you see an increased cost or increased case mix index, kind of trending those things that are increasing against factors that also potentially are decreasing at the same time can be really helpful and easy to communicate quickly in a visual. Okay, and then we promised to bring in a little bit of discussion about resistance in the setting of antimicrobial use as well. And so again, these two graphs show, the one on the left is our overall levofloxacin days of therapy. And on the right is our levofloxacin percent susceptible based on the antibiogram for a variety of different years. I think with quinolones and levofloxacin specifically, it's great to include Pseudomonas in addition to your common enteric gram negatives, because again, that's really kind of a workhorse pseudomonal drug. And so it may help explain where our levofloxacin use is going. There are a couple different ways you can use, sorry about that. There are a couple different ways you can use the levofloxacin data. After a few years of a stewardship program, if you are successful sometimes in reducing your use, you'll see improvements in antimicrobial susceptibility. So if you look at this graph, what I'm seeing is the second to the last bar, year 2020, we were actually starting to see a little bit of improvement in fluoroquinolone susceptibility for our E. coli, Klebsiella, and Pseudomonas species. And then in 2021, you have this dramatic dip in susceptibility. And so what is that due to? Well, our levofloxacin utilization has been relatively low. The graph you're seeing on the left is really trended on a monthly basis. And then unfortunately, our antibiograms are on a yearly basis. But what you're seeing is a direct decrease in levofloxacin use. And so theoretically should not impact, or negatively impact our levofloxacin susceptibility. But what happened in 2020 was a reduction in the breakpoint for CLSI. And so what happened is our isolates are now testing resistant when previously may have tested susceptible. And so what we saw across the board was a 5 to 7% reduction in susceptibility from previous years based on that breakpoint change. And so I think being aware of those things and working with your microbiology laboratory to be on top of those updates is huge, because somebody to the untrained eye might look at this and say, wow, you guys are really messing up our Levaquin susceptibility. Outside of the obvious confounders of antibiotic use isn't the only thing that causes resistance. I think it's important to be able to tell that story and share that information of this was due to a breakpoint decline. Yes, the organisms are ultimately considered resistant and it removes this as a treatment option, but being able to explain that in the setting of a utilization reduction is extremely important. Okay, so we have polling question number 3. So if you guys hopefully are still with me, I'm interested to know what is one potential limitation of utilizing aggregate DOTs as opposed to individual antimicrobial level DOTs. So aggregate DOTs are difficult to calculate. Option 2 prevents evaluation of shifting of antimicrobial use between medication classes, or is better suited for well-established stewardship programs instead of those that are newer. Right. And some 2s. This is great. Awesome. Yep, you guys got it. Okay, so yeah, aggregate DOTs are typically a little bit easier to calculate than individual antimicrobials. And honestly, aggregate DOTs are a great metric for kind of newer stewardship programs or stewardship programs that are newer to being able to report DOT data. So perfect. Thank you guys. All right. We'll go ahead and move on. Okay, so question while we're kind of hanging out here in the chat, and I'm going to go through some of these control charts. Are any of you actually doing uploads and reporting to NHSN? Simple yes, or I am, or whatever in the chat would be great, because I'm curious. Outside of being able to, oh yay, that's great, okay. Outside of being able to do NHSN reporting, I think that this is probably a semi-decent way to infection prevention staff. Oh, lucky. Okay, we're going to talk about this. So advanced trending with control charts. I think this is a decent way to try and justify sustained improvements in antimicrobial use to administration or to other people at a single glance. Those of you that have gone through the Six Sigma program probably know way more about this than I do and could probably explain it better. But what I do know is that control charts are a great way of kind of demonstrating the natural variation within a process and helping identify when there are opportunities for improvement or opportunities for further evaluation. And so with continuous data like a DOT or drug costs, we typically use an individual moving range chart, control chart for trending. So I'm going to talk through a little bit about control charts and potentially maybe there are some of you that are using these. If you are or are not, feel free to let me know. But I've got a couple slides here that are very quick on methodology, and you'll be able to have a copy of these slides as well, so I won't spend a lot of time on it. Essentially what it does is includes a statistical calculation to help identify your upper and lower process limits. Those are essentially your outliers. And 99% of your outcomes processes should fall within these upper and lower process limits. And so everything in between is natural and expected within your DOT use. Anything out of those ranges or above or below the mean consistently might indicate that you've either had an increase in cost, increase in DOTs, or even a decrease depending on where you fall in relation to the mean. So this can be easily calculated in Excel. This is a picture of kind of the template that I utilize routinely. You can also Google, IMR, XMR control charts, and that'll come up with some templates for you. But honestly, I'm happy to share this link with anyone if you're interested. Just shoot me an email outside of the session, and I'll send you our example, and we can walk through it if you're interested. But ultimately, after you do all of those calculations and program those formulas into Excel, what you end up with is a graph like this. And so again, your upper and lower natural process limits are these red dotted lines here. This is essentially natural variation within our utilization. The green line is your mean, and that is the mean of your values that are represented, all of these values that are represented. And then of course, blue is your DOT. In this example is your DOT, so days of therapy per 1,000 patient days. And so that is going to ebb and flow around the mean and within these process limits. If you are looking at a control chart and this is what you're seeing, this is normal. This is good. This means everything is sustained. So even though you're seeing this peak here of utilization, you're seeing some increases in utilization, this is a good way to explain how this is a normal and expected variation in your use. If you have people that are really in tune to this or are prone to asking a lot of questions about, well, why did it increase here but decrease there? These are great control charts are great tools to be able to explain how this is normal and expected. On the flip side, I'm going to show you a couple of examples of out of control processes. So with this process here, if you are looking, again, your DOTs actually fall outside of this upper control limit. And so what that means is that we're seeing significantly higher than expected DOT use. What this doesn't tell you is why, and it doesn't tell you how. All it does is provide this visual signal of something happened in month 3, and it potentially could be impacting our mean. Did we hire, I don't know, a new surgeon who decided that they wanted to use, 48 hours of post-op antibiotics? Did we have, patients who stayed longer who needed more, a higher number of antibiotics? It's really, you can't tell from this, but it is a good visual indicator that maybe we need to do a little bit more digging. Additionally, what this could indicate is that the mean needs to be recalculated, and so that your upper and lower process limits can also be recalculated to better kind of be in line with what your current process looks like. I'll explain that a little bit more on our next slide. So this is a little bit different example. And so what if you are looking at your mean and you're looking at your DOT utilization, you're seeing multiple points here that are all falling below the actual mean of what is calculated. What this indicates is that since we have multiple points that are below the mean, 6 consecutive, that means that we've seen a true sustained reduction in whatever our metric is. So for our example, DOTs. At that point, we can actually recalculate the mean for the month, and this sets us kind of a new mean or a new baseline. The trick, though, is to really kind of sell this point that you've seen a true sustained reduction in antimicrobial use through this chart. That's what this perfect little section right here with the star, that's the story that this tells to people outside of, the pharmacy department. So either when you have one value outside of the control limits, again, high or low, or 6 sequential values above or below the mean, that's time to recalculate your mean and recalculate your process limits. But ultimately, this can be really powerful to tell the story of we've seen reductions and it's consistent, and this is really truly potentially due to our stewardship work. I think that's where I've found the value in these control charts. Okay, so we have a 4th poll-in question, and I apologize, I know it is a lengthy, there's some lengthy responses, but which of the following statements regarding control chart interpretation is false? So option 1 is control charts can be used to visualize natural variations within a process and identify outliers or changes. Control charts may be created in Excel using a standard set of equations and constant value. Values in a control chart that surround the mean and stay within natural process limits indicate that the process is in control and providing expected results. Or values in a control chart that exceed natural process limits indicate that the process is in control and providing expected results. So which one of those is false? I realize it's a lot. Wonderful. Okay, yes, number 4. So anything that kind of falls outside of those process limits is an indicator that something isn't as expected and provides you an opportunity to dig a little bit deeper and take a closer look at what's going on at that point in your DOT use. Okay, so the standardized antimicrobial administration ratio. So I'm going back into the chat here. I'm seeing Nicolette, the infection prevention staff, reports to NHSN. Lauren, Steve, looks like you guys are all reporting to NHSN's AU/AR module, which is fantastic. So you're doing better than I am because we actually just recently had the capability to start reporting. So congrats to you guys, because I think that this is NHSN reporting. It can be kind of tricky, especially we'll talk about some of the technical requirements and things in just a second. So that can be tricky, but the data there's a massive amount of data and it's extremely powerful. What I want to reinforce with everybody is that this is a great way to be able to benchmark your utilization in your facility, either at a facility level or individual unit level, by total antimicrobial use and individual antimicrobial use. You can get all of that information and compare yourself against other hospitals that are of the similar size and actually similar makeup. So how this is done is the SAR is a ratio of observed to predicted antimicrobial use. So your observed antimicrobial use is the information that we input to NHSN every month. The predicted antimicrobial use is a little bit trickier. So for those of you that are also familiar with this or familiar with infection prevention, the predicted antimicrobial use is really based on a logistic regression model that takes into account various factors within hospital systems. So for the predicted antimicrobial use, the general CDC regression model includes total bed size, number of ICU beds, whether or not it's medical school affiliation, And then each individual location, the number of beds per location. So this would be either a medical surgical ward or an oncology ward or a pediatric unit, would be an individual location. So they're looking at the total beds at that location and the location type. So to help kind of adjust for the different types of patients and acuity of patients that each individual location or facility may have. And so essentially they create this predictive model. I think the last time that it was re-baseline was I'm trying to remember, I think 2017. So we're probably due for a reevaluation of that predictive model. And they'll continue to refine it based on the number of sites that are presenting. So this is like any good mathematical model, garbage in equals garbage out. The fewer sites that are reporting, that means the data is less applicable and representative of a majority of our sites. So the more facilities that are reporting that are similar to your size and the acuity and the type of patients you care for, the better data you're going to get out of NHSN when you're reporting. This really is, I think, the input and reliable input and amount of input is so critical for us to be able to continue to benchmark how we're doing and drive more meaningful antimicrobial use. Unfortunately, I think right now there's a low representation of critical access and community hospitals. I think I think there's a lot of lack of representation of some of our more common patient care locations. Not, everywhere is going to have access to a teaching hospital or whatever. And so we need more sites reporting. But really, I think the NHSN sets up a lot of barriers that make it difficult for us to get to that point. So for those of you, again, that maybe are not familiar with this or haven't been doing it, they actually do not allow a manual reporting option for AU and AR. So even though they do allow this for certain infection prevention measures, it's not allowed for antimicrobial use. They require a pretty technical document format that needs to be created by a programmer, somebody who has knowledge of programming and abilities. And then if you are lucky enough to be that person, call me, but also if you're lucky enough to be that person or have those resources, then you still have to pass data validation tests with the CDC. And so a lot of homegrown software programs are sometimes unable to pass this AU data validation on a routine basis. So this is where, it comes into play that a lot of places use third-party software in order to be able to report to NHSN. And so if you are ever just curious or interested, you can find a list of AU vendors on the NHSN website. And, it really is the route that a lot of hospitals go. We do have a partnership with Pipeline RX in the state of Kansas. So as part of KDHE's HAI-AR program, we have been working with Pipeline RX to set up some pilot sites. I know Hayes Med was intimately involved in our first phase a couple of years ago, but really all this does is provide a little bit of support to be able to integrate this module into your medical record so that you're able to report to NHSN, but then also you have access to all of your antimicrobial utilization information, like your dashboard, antibiotic starts, things like that. So it's kind of what you're seeing on the screen here is just one of many options, but I know a lot of you probably have EMRs, like we have Epic, and this is integrated into Epic. I think Cerner has a program, Theradoc, Vigilance, those are probably some of our more common clinical decision support systems. So we do have a couple of minutes. I'm curious, for those of you that are reporting to NHSN, are you doing that through your EMR or are you doing it through a third-party vendor? How is that being done? What are you using? Because we just brought in Bugsy, used to be Icon, but is anybody using like a Cerner version or clinical decision support? Century 7. I always forget about Century 7. Okay. What have you guys been able to do with your data? Have you had the chance to, Tableau is beautiful. Have you guys had the opportunity to really dig into your AU data and share that information with physicians? I know we're like getting down to a minute here, but I would be really interested in some of the approaches that you've taken to make sure that this information is shared, but then also interpreted appropriately, because I think sometimes it's difficult to explain really what the numbers mean, especially if it's just your own internal numbers, or not, you know, if you have people that maybe understand the SAR. Yeah. Yeah, that's kind of the situation that we're into. Okay. No, this was really, really helpful, really interesting. We've started digging around on the SARS and trying to figure out how we're going to use the data in a meaningful way. So that's kind of that is the point that we're at KU. So I would be really interested to maybe get together in a smaller group.
Nikki, I'm going to go ahead and close this room. The other group is already back in the main session.
Oh, okay, cool.
So
well, thank you guys.
Have about 30
for
seconds.
Breakout too. Sounds good. All right, thank you.
Okay, it looks like the other breakout folks are returning back to the main session. Welcome back, guys.
All right, I believe we're all here. So Dr. Wark, you can go ahead and resume when you're ready.
Okay, perfect. If you want to go to next slide, I think we're going to wrap up really quickly, just talking about some dissemination and sharing of the strategies that we ended up talking about in our sessions. So as generally programs, it's most helpful to report data regularly to administration, but also the prescribers, providers, the physicians, pharmacy leaders, and certainly quality improvement. Making sure that leaders or members are present, you know, at committees like the P&T meetings or the IPEC or medication safety committees. Next slide. It's just really important to remain visible. So reporting back what you are tracking, reporting that back to all those different, you know, partners, and making sure that it's drawing attention to the program and also what you're doing and getting more interest, engagement into the program. So sharing about what interventions have happened, what successes, what failures, what issues are that you do anticipate at the facility. You know, it really gets people engaged. And it also helps to keep the institution commitment ongoing. So especially when you communicate these kind of things, and we talked a little bit, maybe half or a third of our time in our session about financial metric pros and cons, which is really helpful. But if you use that as your primary kind of, you know, outcome of your program and how it's saving money, which administration certainly is interested in, but for provider stance, you know, it is it's too fiscally oriented. Certainly the interest for quality and for providers is to know about the value outcomes. So quality and experience, infection, stuff like that. Next slide. So another really effective way to report back information is when you compare the antibiotic use for peers. So you know, comparing prescribing by providers. So, and I know a lot of pushback has happened at our facility, all facilities, is that providers they don't want to be compared. They don't want to hear that they're not doing good, or they don't want to be shamed. So actually a few years ago, a fellow and I did a survey of providers, of prescribers, and you know, this was something that was pretty influential, because we the patients actually or the providers actually were not opposed to seeing their antibiotic usage, nor to being compared against their peers. And so that is something that can kind of help convince administration that that is something that would be very beneficial to reduce misuse. Next slide. So certainly, as I touched on, reporting financial accomplishments helps to, drive and reflect the importance of the program. As we mentioned in our breakout, though, be cautious because you're really going to have most of your savings up front in the first year or so. And so those really dramatic savings may lead to the expectation that you continue to have that many savings. And once it starts leveling off, that they may be cut or they may be reduced or have less interest in the program. So that's just a cautionary tale there. For example, the University of Maryland, they were saving significant amounts for their first few years. And so after they stopped showing these savings, they ended up cutting their program, stopping their antibiotic program. And so within 2 years and when they stopped the program, all those antibiotic costs increased about by a third. And so that resulted in about $2 million in increased expenditure. So keeping that visibility there is important, but not necessarily focusing so much on the cost savings of the program. Next slide. And certainly that's important to maintain institutional support. I think this is actually a redundant slide because based on the return of investment, focusing on the quality that's happening from the program, not necessarily focusing on the finances. Next slide. So this is, and I had posted on our slide while we were waiting on the breakout too to come back, but we'll send out the survey, but we're working on one way to get more engagement and figure out our antibiotic use is to get more facilities implementing the NHSN AU option. And so next slide. So we have created a survey to go ahead and see about the barriers, and we think that it might be financial or commitment, but until facilities actually report back to us, we really want to know more until we can plan to disseminate this and get more reporting back in Kansas, because actually Kansas is we're ranking pretty bad for our antibiotic use outpatient wise. I think we're like 43rd or something. And for stewardship, we're we're actually second to last. So we're trying to really make more of a concerted effort to get facilities engaging and reporting their antibiotic use, because we are really actually not doing a great job in Kansas. Next slide. And certainly, things that we're doing in Kansas to track resistance, we've created a statewide antibiogram. We're going to work on this for the next year, but this is downloadable. Actually, if you want to go to the KDH website, we're working on getting a next 2022 antibiogram. So as facilities have started to release their institutional antibiograms, we'll try to query you to send those back. Last time we got about 75 facilities, so it's a pretty representative of the whole state, and you can look at just your individual region to see what that is. We're also working on creating kind of maps and kind of having so that you could go and click and see what your E. coli resistance is, or certain things that are kind of interactive and more helpful to your region. Next slide. Final polling question. So which of the following is true regarding antibiotic use reporting through NHSN? So sites may input data manually through the NHSN portal. Uploads are allowed in a variety of different formats, including CSV files. And then formatting NHSN data typically requires a validated system for CDA file, which can be supplied by an external vendor or created at your facility if you have someone with advanced programming capabilities.
Looks like we're slowing down on responses. I'm going to close the poll.
So yes, so sites cannot input data manually through the NHSN portal. And so this is something that needs to be kind of integrated into your EHR to utilize that. And so that, again, is one of the ways that we want to help facilities try to coordinate this happening. Next slide. Any questions that anyone has? And I think because it's not unmuted, certainly you can unmute yourself and ask a question too if anyone has anything. I will say also, if anyone is interested more in about the pipeline project, which is what Brenna has been working on for a few years, and Nikki and I are intending to start kind of getting more involvement in, email any of us, Brenna, me, or Nikki, because we'd like to meet one-on-one with you and figure out the logistics of how we can make this happen for your institution.
We do have their contact information on the next slide. So if you are interested in reaching out to Dr. Wark, Nikki, or Brenna, their email addresses are provided, and we do encourage that if anybody does have any interest, please do reach out. They're all very, very helpful. We do have about 5 minutes left. If anybody has any questions at all, please don't be shy.
Or if Brenna or Nikki has anything to add at the wrap up.
No,
guys,
I
it's
was just going to
Brenna.
say, don't be shy. Oh, Brenna, please.
Sorry, I was just going to say that I know that there's a proposed rule from CMS to make it a necessity for certain facility types to use the AUR module from CDC. So that's another thing too. Like if you know that you're one of those facilities that is going to be made to sign up, that, you know, we're interested in doing the project with Pipeline RX, you know, continuing that forward, but also just we're looking for other ways we could possibly help. So just wanted to throw that out there.
And on the next slide, we do have the link for our post-event survey. We do encourage you to go ahead and click the link and fill it out. Because we're using Zoom meeting, it will not automatically direct you to this link today. That's only a feature that Zoom webinar will do for us. So go ahead and click the link if you're able to, and let us know how we did today and how we can better help next time. Our next event will be on July 7th, and we're really excited for all of you to attend that. And it will be the 4th and final session of this series. So thank you for everyone for attending today, and thank you so much for our speakers. It was a great session, and we look forward to next time.
Heidi,
Yes.
we have a request to put that link in the chat so folks could click into that directly from the session.
Absolutely.
I just typed it in there.
Thank you, Dr. Wark.
Hey, Dr. Wark, when you try to do that, it says, we're sorry, we can't find the page you're looking for when you click on that link.
Okay, I'll make sure that it gets in the email that I send out with the link to watch the recording. Thank you, everyone.